Peptic ulcer disease. Peptic ulcer disease refers to the formation of ulcer throughout the gastrointestinal tract. These ulcers form as a result of exposure to the gastric acid. The most prone of these include duodenum, the antrum of the stomach, and the area of the bowel that is near Meckel's diverticulum, since Meckel diverticulum often has gastric mucosa and so forms HCl. Causes include prolonged use of NSAID, steroid use, and infection with H. pylori. The use of NSAID and steroids leads to decreased prostaglandin, causes increase in gastric HCl and a decrease in secretin that leads to decrease bicarb in the small intestine. H. pylori causes gastritis that leads to sloughing off of the cells and ultimately ulcers form. Factors that only aggravate and do not cause peptic ulcer disease include smoking, alcohol, spicy foods, and caffeine. The patient will show burning epigastric pain. This pain will be different from the burning epigastric pain in GERD. In case of gastric ulcer, it will be aggravated with food due to release of HCl in response to food, and in duodenal it will be decreased in response to food. The patient will also have a prolonged history of NSAID in most of the cases, and the pain will be mostly initiated at night around 2 a.m. when the stomach is empty, and in most cases the patient already has developed complication when he presents to you. Complications include bleeding, which will present as melena or hematemesis, perforation. This means that the area of the ulcer either in the stomach or the duodenum gets so deepened that it finally leads to perforation, and the secretions and food etc. ooze out, leading to peritonitis. The patient will present with abdominal guarding and generalized tenderness along with burning epigastric pain. Apart from this, gastric outlet obstruction can also take place due to the healing of the duodenal ulcer. Food cannot be passed down from stomach into the duodenum, and so projectile vomiting will occur. It is said that gastric ulcer should be considered as gastric carcinoma until proven otherwise, whereas duodenal ulcer are never carcinomatous. Therefore, gastric ulcer is and should be always biopsy. Any patient with symptoms of peptic ulcer disease is treated with empiric proton pump inhibitors like omeprazole, etc., instead of doing any investigations. If he does not improve, means the treatment fails, or he has alarm features that indicate carcinoma or complications, only then we go for gastroduodenoscopy. And when we do gastroduodenoscopy and we see that the ulcer is located within the stomach, then we must do biopsy to exclude gastric carcinoma. We can also go for H. pylori screening. That includes 5 tests: a rapid urease test, a C13 urea breath test, fecal antigen test, culture, and serology. Let's jump into some details about H. pylori screening. The rapid urease test involves the use of biopsy specimen. We take that biopsy specimen and grow it in urea containing medium. If H. pylori is present in that biopsy specimen, it will have urease enzyme and it will break that urea into ammonia and carbon dioxide. And so that ammonia, which is basic, will show a pH change and the test will be positive. In C13 urea breath test, we take urea that has C13 isotope of carbon. The patient is given this urea. If his gastric mucosa has H. pylori and so its urease enzyme, only then it will break this urea and will form ammonia and C13 label carbon dioxide. This will be absorbed into blood and exhaled out and detected, and so the test is positive. In fecal antigen test, when H. pylori lives in the gastric mucosa, it releases out its proteins into the stool, which can easily be detected. In case of microbial culture, which is considered as gold standard, we take the biopsy specimen and culture it. This means that the H. pylori within the specimen will be grown and can so easily be detected. In case of serology, we take the patient's blood, and within that blood we find antibodies against H. pylori. Medical treatment in case of peptic ulcer disease depends on the fact whether the patient is H. pylori positive or H. pylori negative. In case of H. pylori negative patient, he is just given proton pump inhibitors like omeprazole, esomeprazole, which decreases his gastric acid and so helps the ulcer to heal and prevents further ulcers. If H. pylori positive, the patient is given eradication therapy that uses proton pump inhibitors along with 2 other antibiotics. This is known as triple therapy. The 2 antibiotics could be clarithromycin along with amoxicillin, or clarithromycin along with a combination of metronidazole. In case this triple therapy fails and the person still has symptoms, we go for quadruple therapy, in which along with proton pump inhibitors and 2 antibiotics, we use bismuth compounds. For example, bismuth subsilate. Bismuth compounds are also bactericidal. They stop ATP synthesis and other enzymes within the bacteria. A related scenario, a 35 years gentleman presents with epigastric pain. Over last 1 year, pain is on empty stomach mostly. He smokes 20 cigarettes a day. This shows a risk factor for peptic ulcer disease. On examination, he has point tenderness in epigastrium. Rest of abdomen is soft. This shows that the ulcer has not been perforated, and there is not generalized tenderness, and abdomen is soft, it is not rigid. Rest of investigations are normal. HB is 13, TLC is 6800, LFTs are normal, urea is almost normal, crate is normal. So epigastric pain on empty stomach shows duodenal ulcer. Smoking is a risk factor, point tenderness, and soft abdomen shows that the ulcer has not been perforated.